Hi everyone, it's a huge privilege to be here, and I think most of the things we've talked about today I hope are touched on in the updated clinical care standard, and I hope it's not too challenging for our epidemiologists colleagues with new clinical indicators and data information. The first thing I wanted to do was acknowledge the Gubbi Gubbi people and the Bindinjara people and recognise the land that we're meeting on today and pay my respects to elders past and present, and also any First Nations people who are here today. And also acknowledge Matua Doug, who's online, and thank him for his help, along with Fritz Evell, who's the Director of Equity at the Safety and Quality Commission in New Zealand, for their assistance in updating the standards on cultural safety. So the clinical care standard, as we've talked about, really is around improving assessment and management and reducing the risk of future fracture. And I think the thing that's been very powerful about this clinical care standard is actually the register, that we're able to look at 80 or 90,000 patients' records in order to be able to update the standard from one standard to the next. There we go. So I'm an emergency physician. I work in a small emergency department at the moment called Belmont Hospital, and it's a 14-bed hospital about 20 minutes from John Hunter. So I've spent most of my career at John Hunter. John Hunter sees around 500 hip fracture patients a year, but I actually think it's really good for all of us as clinicians to work in big hospitals and small hospitals and understand the different challenges and pressures in working in those places. And if I think about the clinical care that we provided maybe 10 years ago prior to the clinical care standard, I think there were things like it's pretty easy to diagnose a hip fracture. Patients have usually got shortened and rotated legs, and we don't even need x-rays, really, do we? But it's actually the coordination of care and the responsibility and the comorbidities and all those issues that we've talked about that stop us from actually getting the person to surgery on time. And I think the clinical care standard has really made a big difference in my clinical practice. So I think, again, we've talked about this today, but I think 1 in 4 people die every year from after a hip fracture, and I think that most families wouldn't actually recognise that. But for those who survive, it's often a life-changing fracture, and as I've touched on, it's around often the complex care needs of the patients rather than the actual care that's being delivered. Many people won't return to their pre-fracture functioning, and for some people that's actually much more concerning to them than actually dying. And so it's an imperative on all of us to do a good job. So hip fractures also cost a lot of money. So the Australian Disease Expenditure Study in 2019-20, I don't have newer data than that, I'm afraid, but estimated $595 million is spent across Australia on hip fractures. And that's just the clinical care. So it doesn't actually take into consideration anything about loss of income or cost to loved ones, which would be much greater than I would have thought, $595 million. When we updated the standard, we did a few things. One of them was we sent out a survey and we got 123 responses, which is good. And 67% of the respondents felt that the clinical care standard had impacted on their practice, and 98% reported quality of patient care had improved since the clinical care standard. So we were very happy with that. So we've got 7 quality statements now. The way we updated it was, so we got the survey results, we could use the data from the registry, which was really important. We also did literature reviews, and we were really looking at what things do we need to change, where are the gaps, and what things do we really need to concentrate on that we maybe didn't think about the first time around with the clinical care standard, and how we could push the boundaries a bit more than we did the first time. One of the things that's interesting about the Commission is that we're funded 50% by the states and territories and 50% by the federal government. So we have to all agree on anything we write. So it's a very powerful place to be, but also can be challenging when you're negotiating quality statements. So some of the things that we've touched on that have changed, we've reduced time to surgery from 48 hours down to 36 hours. We know from the registry data that there's variation in the data from the registry from 16 hours to 92 hours. And so we're aiming now for it to be all patients, not only to the hospital where they have surgery, but from the first hospital that they present. As I touched on, a lot of people are transferred from one hospital to the next, and I think in the registry it was 14% of patients are transferred And we know that if time to surgery, if you're not transferred, the average is 38 hours, but if you are transferred, it's 51 hours. So I think if we're going to really push the clinical care standard, we need to think about everyone in rural and remote Australia and think about how they can all access care. I also think it's important for the larger hospitals and larger health system to think about how they can make sure every patient within their system can actually get access to theatre within 36 hours from, as I said, the transfer hospitals as well. Maybe I'm speaking with my Belmont hat on, but I think that's massively different to what it was in the past. So in our region, ambulance would mostly take patients to the right hospital because, as I said, the diagnosis is quite straightforward. But if they're not and they're taken to our hospital, then we can ring our 24-hour patient flow unit and have the person transferred. If they're not transferred that day, they're transferred at 7 o'clock the next morning when ambulance changes shifts. The next thing we'd looked at was around the orthogeriatric model of care, but being more specific. So we wanted to talk about frailty, malnutrition and delirium. So delirium is actually one of the few mandatory clinical care standards. And I think, again, if I think about our emergency department, we are talking about delirium a lot more now than we used to, and screening people in the emergency department. We're using the 4AT. And then malnutrition and frailty, I think we know are key to improving outcomes, and Jack's here to support me in that. And so there's new indicators related to those three things as well. And as I've touched on, transfers and transitions. So nerve blocks prior to transfer is one of the new indicators. And then the second part's around bone protection medicines. I think this is actually really tricky because the problem is a lot of the patients will have had bone protection medicine before they've had their fracture and probably can't necessarily have access to medicines in hospital because of the timing from their last dose of medication. One of the things I'd actually really encourage you all to look at, if you haven't recently, is My Health Record. So My Health Record is getting better and better. I know it's a long way from where we want it to be as clinicians, but they're actually about to put even private scripts into My Health Record. So if you haven't got access to the data through PBS and data linkage, then it may actually be in My Health Record. But I'm pretty excited about the private scripts particularly because it's actually very hard to measure them. But I think that'll be a good way for us thinking about hip fracture care to know when their last dose of medication was and to know what needs to happen. And also, obviously, making sure that we're writing discharge letters that includes things around what's the plan with the bone protection medicine. So the Commission's website's been updated. And on all these resources are actually available already. I think they started last night. So there's the clinical care standards, there's some fact sheets, and there's some consumer guides as well. And I was thinking about the consumer guides that we've been hearing about today from the My Hip, My Voice, and I think there's probably a whole lot more work we can do. At the moment, as I touched on, we're writing psychotropic clinical care standards, and we've had really good input on easy read documents that we can write, because as you can imagine, the clinical care standard is for people with cognitive impairment and cognitive disability, and it's been excellent. And the QR code. Outside, there's some little cards with the QR code on it. So if you want to pick up a QR code, you can, but it's also there. And I think thank you.